patient of 65 years old. This patient was operated 2 years ago for a colon cancer, left colon cancer. And in the follow-up, this patient developed 2 months ago a jaundice. And the first examination, CT, MRI, and duodenoscopy show an ampullary lesion. And in other hospital, the patient has had the placement of a plastic stent in the bile duct. But the problem today is that we don't have any staging, a correct staging of this ampullary lesion. And also the patient recur the jaundice. And the goal today is to perform a combined procedure. The first procedure is the EUS to assess the staging, the precise staging of this lesion. In particular for the bile duct, for the pancreatic duct, to know if an endoscopic resection is possible or not. And the second procedure will be or an ampulectomy if the lesion is endoscopically resectable, or and probably more probably will be to exchange this plastic stent for another stent because the patient has always a high level of bilirubin. Okay, I will start the examination. I use the other scope from Pentax. This is the slim EUS scope, the EG32 UT, okay, which is a small EUS scope of 11 millimeter of diameter, and with a very small probe of EUS probe. It's always connected to the previous machine. The advantage of this scope is that we can pass easily the stenosis, and also we have quite a nice image, endoscopic image. Okay, now I will go quickly into the duodenum and to try to see. Try to see the lesion. I aspirate some bile in some liquid into the stomach, and now you see I did the same maneuver, and you see the stent here, and probably the lesion is more invasive than suspected by the first examination. Now I will start the EUS examination. Here we are at the level of the head of the pancreas, and here we have the inferior vena cava. This is the duodenal wall, and this is the papilla area. Now I remove a little bit the probe, and I push, I do up and I push my scope to try to see the papilla. A good landmark in this case will be the stent, because the stent is in the bile duct. But this also can introduce some artifact. But the plastic stent is less a problem than the metallic stent. Okay, and here you see the lesion. Here, I increase it a little bit. And you see that this lesion is not limited to the duodenal wall. Here you see the muscularis of the duodenal wall, and this muscularis disappear here. And this is the lesion. And this lesion is an invasive carcinoma. And there is no indication for an ampullary for an ampullary resection, but this patient should be a candidate for surgery. Here you see that you have involvement of the pancreatic tissue. This is the pancreatic tissue, and here you see that the muscularis of the duodenum disappear. Now this is almost a T3 lesion of the papilla. Here again, you see the lesion. This is the pancreatic duct. Okay. Now I will put some water inside the duodenum. Can you give me a syringe of water to have a better view of the lesion? Here you see that this lesion is again an invasive lesion. Here you see that this border, irregular border, with infiltration of the duodenal of the pancreatic tissue, and this is the pancreas with the pancreatic duct, and you see this lesion here. Okay, now I will put some water inside the duodenum. And here you see again the lesion here. This is the lesion, and this lesion is an invasive lesion. Okay. Here again. And there is a small note. Try to show you. Here, there is probably a small note. Okay, this is the pylorus. Okay, now I think the next step is to do a complete examination of the transgastrically. This is the left lobe of the liver with some dilatation of the duct, and this is the dilatation. There is some air inside, and the ducts are dilated here. And this is due to the obstruction of the plastic stent. This is the pancreas. There is no dilatation of the main pancreatic duct here. This is the confluence with the superior mesenteric vein, also is free, and the superior mesenteric artery, which is here, it's also free. There is no contraindication for surgery. Okay. And this is the tail of the pancreas. Okay, now I just check quickly the left lobe to be sure that there is no small metastasis. Here you see that there is a dilatation of the duct, but not metastasis. And there is no contraindication for surgery in this case. And I think now I will change my scope for the duodenoscope to change the stent and to perform a new series of biopsy, because there is no histology for this patient. Okay, now we change the scope and we come back for the RCP. Okay, I introduce now the duodenoscope, and I will go quickly into the duodenum. I use also the CO2 exfiltration, and now for all therapeutic procedure we use the CO2. Okay, there is some liquid. I aspirate the liquid, and I will try to find the pylorus here. Now I push and down with the scope, and now I straight my scope to be front of the papilla. And you see that this lesion is an infiltrative lesion. It's not a lesion for ampulectomy. And I think the first step is to remove this stent, which is occluded. And you see that the stent is occluded here. Okay. I will use a snare to remove this stent. And the trick is not to open fully the snare. It's just to open a little bit the snare to catch the tip of the stent. You see? Open a little bit more, like this, because it's easy to manipulate the snare. Okay, close, and now I can remove the stent through the working channel of the scope, and it's quick. And now I will give me some water to clean and to try to have an ID, an endoscopy ID of this lesion. And you see this lesion is an infiltrative lesion. There is an infiltration of the bile duct. This is not a candidate for the endoscopic resection. Okay, this is the pancreatic orifice and the bile duct here. Now the next step is to do a cholangiogram. I will use the ball tip catheter. You see here we have the pancreatic orifice, and this is the bile duct here. Okay. Now I will go into the bile duct. There is a stenosis here. It's not easy. Even with the sphincterotomy, you see that you have probably infiltration of the bile duct by the tumor. You can inject. X-ray, please. Nothing happened. Stop. Okay, now we have a deep cannulation of the bile duct. You can inject, please. Inject, to obtain a cholangiogram. Inject. And you see that the stenosis is a long stenosis. Hein? Voilà. Cliché. Photo. There is a long stenosis. Is a 2 centimeter stenosis with infiltration of the bile duct. And I think this is an extension of the ampullary lesion to the bile duct, or it's a cholangiocarcinoma of the lower part of the bile duct with infiltration of the papilla. Okay, now the next step is to put a wire inside and to perform a brush cytology and the biopsy to obtain the diagnosis of this stenosis. Okay, now we use a 0.035 inch hydrophilic guide wire, X-ray. Go inside. Stop. Now we do the exchange. Okay.
What do you need to give you now? Do you want the cytobrush?
Cytobrush and biopsy, both.
Get out, huh?
Yes. You need that, the combination of both. are more accurate than the use of the only one technique. And I will use first the brush cytology, the Cook brush. The technique of brush is to apply back and forth movement of the brush cytology at the level of the stenosis, and after we in your institute we cut the brush, and we leave the brush inside the cytolith. And the cytolith is the same liquid that we use for the USFNA. Regarding the biopsy, the minimum number of biopsy is 3. And the accuracy of the biopsy increase with the number of biopsy. And the best accuracy is for more than 3 biopsy. A little bit traction, please, on the wire. And this is the catheter, 8.5 French catheter. You have some resistance at the level of the stenosis. Now the stenosis is passed. X-ray, please. Okay. Open the brush. Okay. And now I start brushing. Non. La brosse dehors. Out. Dehors. Okay, yes, you see the brush here on the endoscopy image. And now I did the brush. I brushed the stenosis. You see the stenosis is mainly here. Here. I did a 10 passage. I think now it's okay. You can enter the brush and you do the exchange. Okay, perfect. Now we will put the brush into the cytolith. Now open the cytolith and open the brush. C'est plus simple. Voilà. Vas-y. Push the brush out. Now it's very important to move a little bit, and after to cut. And the brush is inside the cytolith. And this is easy for the pathologist to have the cytology of the bile duct. Yeah. Now the second part now is to perform the biopsy. We use a biopsy forceps. Close. Okay. And I leave always the guide wire in place because is the security. And now the technique for the biopsy is to put the tip of the forceps close, of course, at the entrance, and and with the elevator to try to enter here. I'm not in a good position. No. Yes. X-ray. Now the forceps is inside the bile duct. Open the forceps. Okay, now the forceps is open, and I pull back the forceps just underneath all the stenosis here. Now I push against the stenosis, close. Okay, and now we have one biopsy. Here you see now very well the tumoral infiltration of the lower part of the bile duct. And I'm convinced that this case is more often a cholangiocarcinoma of the lower part of the bile duct than a real ampullary lesion. Okay, again. Open. Close. Okay. And the last part of the procedure will be to insert a metallic stent because the patient has a high level of bilirubin, more than 100. X-ray, please. Open. Open, open, open. Close. Perfect. And one more. And we plan to put a 6 or a 4 centimeter uncovered stent because a small metallic stent is not a contraindication for surgery. The only problem with the stent is the long stent, the 8 centimeter, because the tip of the stent will arrive at the level of the bifurcation, and this can the surgeon can have some problem to perform the anastomosis, but using a 4 centimeter or as it open, close. Okay. I think I will use, in this case, a 4 centimeter. X-ray, please. Yes. I will use a 4 centimeter uncovered stent. Okay, now I'm close as possible of the papilla. And you see the stent now, and the stent is in place. X-ray, it's a good, the good dimension. You can start to open, not too long, not too short. Okay, you see the yellow marker, which is the lower part of the stent. Open, open. Completely open, open. Okay. X-ray. Okay, this is perfect. This is the perfect position of the stent. You see a lot of bile is coming. Okay, now I remove everything. X-ray, fin cliché. And now a photo without the scope of the X-ray. X-ray, please. Okay. And now the procedure is finished. And when this patient, when the jaundice will disappear, this patient will be operated of a Whipple resection.